If you look at the numbers behind incontinence in women, it's hard to believe just how big an issue it is. Incontinence affects more women than diabetes, breast cancer, and heart disease, but it doesn't get nearly the attention it deserves. That's why the National Association for Continence has created the We Count campaign to help you realize that this isn't just a you problem, it's an us problem. There are treatments available right now that can make a real difference in your life, and we invite you to take action today. Visit nafc.org/we-count for essential facts, insights, and resources on stress and urge incontinence, overactive bladder, menopause-related leakage, and more. That's nafc.org/we-count to learn more and discover that there truly is strength in numbers.
Welcome to Life Without Leaks, a podcast by the National Association for Continence. NAFC is America's leading advocate for people with bladder and bowel conditions, with resources, connections to doctors, and a welcoming community of patients, physicians, and caregivers, all available at nafc.org. Welcome back to another episode of Life Without Leaks. We're talking today with Dr. Toby Chai, Chief of Urology at Boston Medical Center, Professor and Chair of the Department of Urology at Boston University School of Medicine, and most recently, the recipient of the National Association for Continence's 2022 Rodney Appell Continence Care Champion Award. Dr. Chai, welcome. Thank you for joining us.
It's a pleasure to be here, Bruce. Thank you so much for the invitation.
Excellent. Thank you. Now, I was hoping you could tell us a little bit about yourself. How did you get into urology?
I would say one of the driving reasons was my teachers at Indiana University School of Medicine were wonderful people. They showed interest in the students. And so naturally, students want to follow what their teachers, they want to do what their teachers do. So that's pretty much what got me into urology. But I would say subsequently, after I got into urology, I realized it's such a big field. And I was very lucky to encounter Dr. Edward McGuire during my residency at University of Michigan, who was one of those people I think most would consider him a leader in the field of continence. And that's how I got, interested in bladder function, urinary continence, urinary incontinence. And he taught me many things, mostly clinical. And then I would say where I am today, I would put some weight on my last teacher, which is Dr. Bill Steers, who was at University of Virginia, where I took some time off and did research in bladder physiology and got to think like a scientist and do experiments to answer mechanistic questions related to bladder control. So that's how I came to where I am now.
Outstanding. So tell me a little bit about your practice as it is today. Do you specialize in anything in particular, or are there any particular types of patients you tend to see?
Yeah, so I got grandfathered into the subspecialty called female pelvic medicine and reconstructive surgery, or urogynecology, as it's now going to be called. I did not do a formal fellowship in that, but because of, my long-term interest in this area and concentrating clinically in this area, I got what they call grandfathered into the subspecialty because it was just created in 2013. So my patients typically are anybody who has a bladder complaint.
You're saying that this really only got created in 2013, if I heard you correctly? What is it like working in something so new, and what does it mean to have something so new?
Well, obviously the patients aren't new. They've been around. I think this subspecialty was recognized by what is called the American Board of Medical Specialties in 2013. The official recognition just means there's a structure for education, testing, and recertification. So just formalize people who are doing this area such that there's standard operating procedures now, so to speak, in getting this certificate of subspecialization. But the patient problems have been around, obviously, before 2013. And the people who did a lot of this obviously went to all the same meetings, talked to each other, but now there's a piece of paper one could hold. This is a way pretty much any subspecialty area has developed in terms of getting an ABMS recognition.
Okay, that makes sense. So are there any sort of particular common types of conditions or set of symptoms that you tend to see, or does it run a really broad range?
Well, so usually it's urinary incontinence being a big area. voiding difficulties being another area, lower urinary tract symptoms. That's a term that most people understand, but urinary frequency, urgency, nocturia, certainly bladder infections. And then I also, because of the reconstructive surgery, will have anatomic problems with the urinary tract that impedes urine flow, obstructions, and things that basically are anatomically oriented that may need surgery to solve.
Okay, well, that sounds like you have a pretty varied day on a typical day, I would imagine then.
It's very fun. That's why I'm still doing it. I love seeing patients smile when they've been helped, and that gives me the energy and impetus to continue to go forward.
Now, I'd imagine that a lot of patients would not use the word fun when they're describing what it's like to have to go to visit a urologist. I guess you could probably deal with a lot of apprehension, maybe some embarrassment, some people who are a little reluctant to discuss what their symptoms are. Is that a fair characterization of a decent group of patients?
I would say to a certain degree. I think we live in an age of information overload, and we have a lot of access to information. And I do believe that talking about what I call quote unquote taboo subjects have been sort of, those barriers have been knocked down in other areas of medicine as well. There are going to be, for sure, people who I think are less open to talking about these areas. Mm-hmm. But for the most part, I myself always am trying to get the patient side of the story. And so I think my philosophy has always been try to develop a rapport with the patient so they feel comfortable saying what they need to say.
I guess, though, since you are a specialist, many patients have already had some sort of conversation with the primary care physician, or do you get a lot of people just coming directly to you?
Yeah, so that's another good point. I would say my practice is primarily referral based. So they have had to, talk to somebody else like the primary care doctor to get a referral into my practice. Although most urologists are open to just a patient calling in and making an appointment, but probably over 70% of my practice is referred in patients or patients referred from other providers. So when I see the patients, most of them have already had to talk about their bladder problem with another healthcare provider. So I guess I'm lucky that it makes it a little simpler for me already.
So tell me, what do you think are the biggest challenges facing the field of urology today?
I think it's not just urology. I think it's medicine in general. We're becoming so corporatized. I hate to use this analogy. We're becoming like McDonald's, where the service is impersonal. You can't get a hold of the doctor, and everything seems to be a checkbox. I understand the reasons for that. Obviously, there are benefits, and we can go too far to one side. Life is always about a balance. We tend to swing from one side to the other side, sort of headlong a lot of times without trying to hit that perfect balance. But what's the challenge for urology? The challenge for urology is understanding that, the best doctors are 3 A's for the best doctor. It's ability, affinity, and availability, and not in that order. So how do we make the doctor have all 3 A's?
Tell me this, from a patient's perspective, what do you think are the biggest issues or challenges that are facing urology today? If you could put yourself in the seat of a patient who's talking with you.
Yeah, so I think if I were a patient, I think access is an issue because appointment times are getting longer and longer. I think I also want to be able to talk to the person who has most expertise about it. And it's not always a doctor you're going to see, right? And I don't mind seeing a nurse practitioner or a PA, but somebody who obviously knows about your problem and then cares about your problem. It's actually probably the same 3 A's I just talked about, what makes a good doctor. I want a doctor or a healthcare professional that have those 3 A's. And the other challenge I think as a patient is the interference between a patient and the healthcare provider, and the interference by the third party, which is like insurance companies, telling doctors and other professionals what they can and cannot do.
Yes, I think that's going to resonate with a lot of people. There's a frustration all around on that. So I'm wondering, when somebody comes to you, and I suppose this is probably an unfair question because you described an enormous range of different problems that people will be visiting you for, But can you tell us a little bit about outcomes? I mean, what sort of are the range of outcomes that patients with typical urologic problems can expect? Are we talking about cures for a lot of these conditions? Are we talking about better ways to manage? What are you thinking?
So, what's interesting is cure is an elusive four-letter word. And I actually don't like the word cure because I think, how can I put this? Every day we live, we're one day closer to the end of our life, right?
Mm-hmm.
And I don't think we could ever say that is not the ultimate reason. And I don't want to get so morbid here, but getting back to outcomes, I'm trying to be, sort of put this in perspective. I would call my field functional urology. It is not cancer. So I think everyone's familiar what cancer is because that is a very, big area of medicine. Mm-hmm. Outcomes in cancer has what we call hard metrics, overall survival or disease-free survival. Those are, I think, relatively easier to count than functional urology outcomes, which are patient-reported, which are subjective, which are dependent on a lot of other factors. So I think to define outcomes in functional urology, it's a little bit of a softer area. The word soft means that you can count it in different ways, and people may not always agree in how you counted it. I think the other thing that we really have to think forward is we got to put patients' expectations into the outcomes, because I don't think every patient have the same expectations when it comes to functional urology.
What sort of expectations do you think are more realistic?
Let's say you have somebody who has a lot of comorbidities. Okay, they're diabetes, high blood pressure. Maybe they've had a stroke. This is a person who can have all three of these. Maybe they're partly disabled, maybe more frail. Is the expectation of that person for a functional issue going to be the same as a patient who has, say, less comorbidities? And again, I think this is going to have to be patient-centric, and I think patients can be realistic. Some of patients may be less realistic, but I think we sort of have to query the patient what their expectations are. Because many times, doctors have their own expectations. They're expecting a patient's going to agree with their own expectations.
Now, before a patient comes to see you then, what do you think a patient should be doing to help, maximize their opportunity for some successful outcomes?
I think a patient should really do some homework and understand, about their symptoms and, their condition. Now, I understand there's people who say, oh, don't go on the internet. It's full of bad information. But, there's some information there that can be trustworthy, and you can find from the internet some background information. And I think writing some questions are really important to ask the doctors about your condition. And finally, what I said earlier about if patients don't say it, I always say, well, what do you expect to get out of this visit? What do you want to know? And, sometimes it's as simple as, oh, I just want to make sure it's nothing more serious.
So what about things like bladder diaries? Are you a fan of those?
Yeah, I mean, I think a bladder diary is important. Now, I don't get a bladder diary on everybody, carte blanche. It gets back into, here's a funny way I think about the bladder diary. When I want to separate it between a sort of a lower urinary tract problem, which the bladder is part of the lower urinary tract, versus a non-lower urinary tract problem. And what do I mean by that? So a bladder diary, I'll give you a practical example, can pick out a person who drinks way too much fluid, because when you add up the total volume voided in the bladder diary, you realize, oh my gosh, there is something outside of the bladder world, because drinking fluid is a behavior. It's drinking fluid. It's kidneys concentrating, urine or not concentrating urine. So someone who has polyuria, which is basically too much volume of urine made, will be picked up by the bladder diary, but that isn't a bladder problem. So for me, a bladder diary helps me separate, not perfectly, but in a global sense, it can help me sort of stratify patients into different causes of their bladder problem.
So another question regarding speaking with patients. Do you find that they expect that you're going to be offering them medication, you're going to be recommending treatment like surgery or an implant or something, or are they expecting you're just going to tell them to use absorbents or change their behavior? What do you think their expectations are?
Well, so you've mentioned a lot of things in what I call my toolbox. So I'm willing to offer anything that I can do to try to help a patient. Now, there are what I call societal guidelines for different conditions, whether it's stress incontinence or overactive bladder / urgency urinary incontinence. And so there ways that we're supposed to follow things based on the guideline. But, guidelines are sort of just that. I mean, they don't necessarily dictate what you must do. But so when a patient comes in, I think every patient has different expectations, but it's my job to explain to them the different options and say, we probably do something least invasive. It doesn't matter what the functional urologic problem is. We always think less invasive to most invasive. That's a way, because it's a non-life-threatening disorder we're treating. For the most part, very rarely would it be life-threatening.
Say, for example, medication or surgery does make sense for your patients. Is there some resistance to that, or are people pretty open to whatever makes sense?
It depends on what I call the risk-benefit profile is. And again, this is part of also a process called shared decision-making. You present patients options. You talk about their expectations. You talked about medicine. You talked about surgery. So we have to explain what, not every surgery is surgery, right? You can do a minor surgery, that's called surgery, or you can do a heart transplant, that's also called surgery.
That's right.
So some are major surgery, some are very minor surgery. So you have to explain what each step, what it entails, and the benefit risk profile of each of those. And of course, people will say, oh, medicine is probably less risky than surgery. Well, it depends on which medicine you're talking about also. And so patients then have that education and that information, and then can hopefully, again, help me as the treating physician come to a consensus decision between the provider and the patient to select what's right for them.
What about third-line therapies? I would imagine patients really aren't very familiar with them.
Yeah, so third line, I think you're talking about overactive bladder, third line. So first line is behavioral modification. Second line is medications. And then the third line are the surgical options, which again are relatively minor surgery in the bigger scheme of things. But they're Botox injection in the bladder or sacral neuromodulation, which is putting a lead into the third nerve root foramen in the sacral bony area, and then hooking up that to electrical or battery that provides electrical impulses to stimulate the nerve to help control the bladder to reduce urinary frequency or episodes of urgency urinary incontinence. Again, there's pros and cons for those two third line options. There was one large randomized trial comparing Botox injection in the bladder versus the sacral neuromodulation. And even after having read the trial, one does not jump out. It just depends on different factors that maybe even what a patient's sort of a whim, what by whim, it's not scientific. It's like, oh, I just don't like that because they heard something that make them think a certain way. That's kind of whimsical, so to speak. But both are effective, if you will, but they have different side effect profile.
Now, but that does bring up another point, because I would imagine that to a lot of patients, when you talk about things like sacral neuromodulation, it sort of sounds a little futuristic or innovative. What do you see as innovation in the field of urology? Do you feel like it's sort of behind the curve in terms of medical innovation, or keeping up with things, or ahead of the curve? Any thoughts on that?
Sure. Well, traditionally, I think I'm very fortunate to be in the field that has been populated by innovative thinkers. From the days of shockwave lithotripsy brought to clinical practice by urologists, which basically it made open surgery on kidney stones obsolete. It just totally stopped surgery. To, being the specialty that drove robotic assisted laparoscopic surgery in the pelvic area, specifically in prostate removal for prostate cancer. Urologists have always sought the most innovative way to do things. And I think I do want to just mention this. It is very important to maintain innovation. The whole thing about intellectual property and being able to have a marketable product that makes a profit for the company, those are also important. Earlier on I mentioned insurance companies, and I try to be balanced in everything I say, because there are always two sides to every story, right? There's always the pros and the cons, and we don't want to sway too much to one side or the other. But innovation involves ability to, create something, market it, and make money. That's part of the innovation aspect. And so early innovation is always going to cost more, right? And things tend to get cheaper as the product gets more mature in the market. But in terms of functional urology, where innovation is, well, we talked about, sacral neuromodulation and Botox injection. Both of those came out during, I'm sorry, they were not during my training, it was after my training. So in my lifetime, I saw those two treatments come forward. And I'm loath to not mention, I totally forgot another, and whether you put it as second line and third line, even the document I helped create in the first version, the OAB guidelines, I forgot where posterior tibial nerve stimulation, but that's a external nerve stimulation on the ankle area where you don't have to have an implant, although there's some new products coming down the line on posterior tibial nerve stimulation where it's a small implant. But one area that I think needs more innovation is drug therapies in the area of functional urology. I think a lot of the pharma companies got out of developing drugs after beta-3 agonists, and call it what you will, market forces, lack of interest from the stakeholders, but we seem to hit a rut in pharmaceutical development. But hey, down the road, who knows? These things tend to come in cycles also. There's downtrends and uptrends, like the stock market.
Considering the literally millions of people who suffer from these conditions, you have to think that there are some drug companies out there that would find the research worthwhile.
I hope so. I mean, I'll give you another drug product that has a hard time being developed is antibiotics. And I'll tell you why antibiotics have a hard time. And I think doctors are partly guilty for because doctors and other healthcare providers as well, we tend to overuse antibiotics such that, and we're getting better. There's a whole concept of antibiotic stewardship, which means being a good steward of the resources that we have. So, but bacteria develop resistance to antibiotic. They always do. So even a new drug, new antibiotic that gets brought out, like in, 5 years, it may not be good anymore because of the bacteria resistant to it. So the drug companies are loath to bring on antibiotics because the return is too short and not guaranteed in terms of financial investment and the return of investment.
So speaking of research, do you happen to be involved in research yourself, or do you concentrate most of your efforts now on seeing patients?
Well, research had been the mainstay of my career for, I would say, about 20 of my 23 years. It's only after I became the chair of urology here, I sort of said, I have a big proportion of my life now spent in administration and running a department. So I gave up my lab when I started my chair position, but for 20 years, I ran a basic science lab. And as you heard about my own background, I had, additional lab postdoctoral training when I finished my residency. So I've done a lot of lab research. I've also done clinical research, specifically in urinary incontinence as part of the NIH-funded urinary incontinence treatment network. So I did both basic science as well as clinical science and loved both aspects. But, discovery is really, really fun. And the pleasure of looking at results that suddenly the light bulb goes off and you found something new you will always remember those days.
So that brings up another point. So you have had a really notable career over more than 2 decades. What achievements do you think you're most proud of if you had to go back and pinpoint that?
Well, so professionally, I would say it's being able to successfully balance what I call the research side of my career and then the clinical side of my career. The ability to do both, I think, is always challenging, and there's not a real clear-cut way on how to do this. I will give a lion's share of the credit actually to my wife, who's also a physician, and I think she made the conscious choice of forgoing her career and say, you go do your career, and I will be happy doing what I want to do, but you go pursue your thing. And so I was able to have, I think, a little bit more flexibility and time-wise of being able to balance that sort of that research aspect, as we were just talking about, and then also taking care of the patient aspect. So that's what I'm most proud of, is being able to do that. But, I had a lot of help.
Now, you were just selected as the NAFC Continence Care Champion for 2022. Can you talk about what you were cited for in particular that helped you stand out?
You know what? I will make this little statement. I wish life would continue in the way that when I was being promoted through the academic ranks. I'm a full professor now, but you have to go through assistant, associate, and full. I was told, the way it works is you just work hard at your job. Then one day you come in, someone pats you on the back, says, congratulations, you've been promoted to the next rank. And you go, oh, great. And then just go back to your work and you do your best. But nowadays, people know what the criteria are for, both promotions or winning an award or whatever. They know I have to have all these things. And I think then we become sort of this metric oriented thing, and you're not pursuing something because you want to, because you like to, because this is what drives you. It becomes, and I get it. You do have to know the criteria. It has to be transparent. The medical school has to let you know. So I'm not here coming to work and say, I need to get an award, and this is why I need to get an award. It's like, how do I do my job well? How do I pursue what I'm interested in? How do I help the patients? I think I've been able to pull off those different things in the balance well enough to where I think they said, oh, he's worthy of the CCC job. But I don't really know because, at the end of the day, I could say, oh, is it this award or that award? But I'm also a little bit embarrassed by all the awards because it also reflects a lot of the people who've helped me through, all my time, like my lab. It's a team effort when I was doing lab work. There are a lot of people doing stuff. But no, I was very honored to get the CCC, but I hope it's because I was successful in, the different domains that I was talking about earlier of what I needed to do.
I mean, it's not just the NAFC that's recognized you. You have a list of awards that I would imagine is the envy of a lot of people in your field. You've got the American Urological Association's Politano Award for outstanding work in achievement of urinary incontinence innovations in bladder research, the Society of Urodynamics Female Pelvic Medicine and Urogenital Reconstruction's Distinguished Service Award. That's some pretty significant recognitions. It does have to be rewarding, I would imagine.
Well, yeah, thank you. I like to be pleasantly surprised by research results. So getting the awards, including the CCC, I'm very honored, obviously, and this is something that I would have never dreamt that I would have won, but I think it's just me keeping my nose to the grindstone and, just come in, do my work, be happy with what I'm doing. I've been fortunate. So in our little discussion, by my teachers, by my patients who I like seeing their smiling face when I'm helping them, by my team when I'm in the lab, coming up with interesting results. So I think, my life has been very fortunate, and it's a reflection of a lot of different people.
That's excellent. Now, I think, did I hear correctly? Did you mention something earlier about writing the standards for OAB or something along those lines?
Yeah, so I was in the first version of the OAB guidelines, the AUA SUFU OAB guidelines.
Can you tell me a little bit about what that means?
So it was basically getting a synthesis of all the literature on OAB treatment and trying to look for what level of evidence each of the treatment is, and then writing up a white paper on recommendations based on synthesis of the data that has been published. So that's where we got the first line, the second line, the third line that we were talking about earlier.
So I would imagine that's got to be very meaningful for the entire industry then.
Yeah, exactly. There's been actually two more versions, which I only participated in the first version. And obviously that's the basis that the second and the third were based off. But I think, yes, many in the industry, many in healthcare, they look at the guidelines as sort of the standard paper, if you will. And so those kind of papers are interesting to write. They're not certainly hypothesis testing. That just means doing experiments to find out if your idea is right or wrong. Mm-hmm. It is really just reading lots of papers or hearing about the summary of papers from professionals who actually know how to extract that data, and then coming to a consensus amongst a group of experts.
Can you tell me, when your patients come to see you, do you see any common misconceptions about urology or incontinence or what you're able to do for them that you might be able to disabuse them of?
So I think one misconception is urologists just see men. And I think urology has a big prostate-centric type of concept, with prostate cancer and BPH. But some patients seem surprised that we also take care of women.
That also does bring up another thing for right now. Is there anything else that you wanted to mention?
As I've gone through my 23 years or so of doing urology, I've appreciated a lot more in the area that I'm doing, which is, again, bladder-related conditions, as well as, urinary incontinence, is that there's so many other body systems, biological systems that affect bladder function, from the brain to diabetes to other neurologic problems. I hope one day as we move forward, that we'll be able to look at a patient when we evaluate them and be able to tell what proportion of their bladder complaints are due to any of the biological systems. I only mentioned 2 or 3 of them in what I just said, but I know there are many more. And if we get all of those that we know and develop a way to test for that patient and then say, hey, your bladder problem is 70% in the bladder, 10% in the urethra, and 10% in the brain, is that 80 or 90%? But whatever adds up to 100%, you can name all the different systems based on a panoply of testing you do. So then you can direct treatment in a more sort of directed type of way, instead of using sort of what I call the guidelines way, which is we try this one treatment for a symptom that we don't really know the mechanism for. So I'm looking for the future where we get much more precise and we get personalized for each patient.
That's encouraging. You think that we can realistically get there?
Of course. That's why I'm so happy doing what I'm doing, because I think we're close.
Well, Dr. Chai, I want to thank you for joining us today. I really appreciate your insight. I want to congratulate you on receiving the Continence Care Champion Award and all of the other honors that you've received as well. And look forward to seeing your continued success in the field, and for your patients to continue to receive the excellent care from you as well. So thank you for joining us today.
Thank you, Bruce. My pleasure.
Life Without Leaks has been brought to you by the National Association for Continence. Our music is Rainbows by Kevin MacLeod. More information about NAFC is available online at nafc.org.